We're so glad to have you with us today. Good afternoon. If you weren't aware, you have joined us for Faith, Trust, Hope, and Advocacy, effectively engaging faith community leaders to address disparities in serious illness care. We are very excited about being with you today. I first of all want to say thank you to the organizations who have made this possible for us today. C-TAC, one of our partners, NHPCO, and also the National Partnership for Healthcare and Hospice Innovation. These three organizations came together behind the scenes, and we talked about the need to be able to impact our faith communities and to be able to have a dialogue this afternoon to really look at the disparities in serious illness care. You know, nothing happens in a vacuum. And so today is an example of these organizations coming together with us being able to see that we have to collaborate, we have to work together to make change. And so today I'm excited about those who are joining us today, our panelists. And I want to take a moment just to introduce them to you at this moment. First of all, we have Reverend Brandon Brewer, who is the Director of Patient Experience at Accent Care Hospice in Maryland. One of the things that Brandon has been doing a lot of over the last 21 years, he has worked in the area of chaplaincy and spiritual care. And 10 of those years have been devoted to hospice and the end-of-life care. Another thing that's very important about the work that Brandon has been doing is that he has been engaged in looking at how we can do evidence-based spiritual care and looking at those outcomes. And he's been very engaged in research as well related to equity, inclusion, and looking at spiritual care at the end of life. Next, we have Donna Gales, who is the director. Donna is the director of client relations in DC and the associate director at Capital Caring Health Center for Equity, Inclusion, and Belonging. One of the things about Donna is that she's extremely passionate about engaging with our communities where they are. And she's also very passionate about empowering our communities and giving them the right education that they need about serious illness care, but in a manner in which they can receive it. Last but certainly not least, we have with us today Elder Angela Overton. She is the Senior Advisor to Coalition to Transform Advanced Care, which we affectionately know as C-TAC, and she is the Senior Advisor for the Interfaith Advisory Council. One of the things that I love about Angela, as I've gotten to know her over the last couple of years, is that she is passionate about bringing God's holy divine love to people practically, as well as demonstrating that through how she educates and how she connects. And so today, you guys need to buckle up because it's going to be an amazing afternoon of dialogue with our panelists. As you know, over the last 2 years and 10 months, we have been living in the midst of a public health emergency called COVID-19. I can hardly believe that we're almost at the 3-year mark in the midst of this pandemic. And during this time, we have seen more than 840,000 people who have died, and more than 60 million have been impacted with a COVID-19 diagnosis. In the middle of all of this, it has shined a light on the fact that many of our communities of color have been impacted disproportionately during this pandemic. And so today, as we sit down to have this dialogue, we want to talk about how the faith community can help us reduce or eliminate these disparities. We're going to look at the issue of faith and how faith impacts our communities. We are going to look at how trust is developed and how trust can be broken. And yes, we're going to talk about how we can bring hope back to our communities. With so many being living post-COVID, so many having lost loved ones, hope has been battered. And so today we want to talk about how we can resurrect hope for our communities. And lastly, what do we do from a public policy perspective? how do we advocate to make change and to allow for our communities to be involved in the change process. So with that, let us get started. You know, the very first question that I want to ask, I want to address to Angela this afternoon. Angela, what do you feel are the most critical changes that we have to make to face the future effectively if we're going to improve healthcare for the underserved?
Thank you, Marissette. First of all, I want to say thank you for having me. I am delighted to be among great constituents, a cohort, but more than anything, it is being in a community with other individuals that want to not only talk about change, but let's be the change. So thank you for having me. It's just an utmost privilege to be here. To your question, there are a few things that in my experience, we must do. We must work in partnership. This is community workers, the CBO organizations, community-based organizations. This is payers, this is stakeholders, this is clinical providers. This is a key component of that is spiritual leaders who are community-minded, who are already on the ground doing the work. We must work in tandem. We must work in partnership with one another before we come up with any IE solutions. In of itself, if we do not work with each other, we will not improve our healthcare systems. We also must have Medicaid and Medicare reform, payment reform. Ensure that Medicare and Medicaid provide expanded funding for a package of community-based services, especially for those most in need. Care planning and decision-making is more accessible and equitable. We will not be able to do this in the realm that it needs to be done if we do not have Medicare and Medicaid payment reform. Thirdly, we have to rectify food, transportation, housing, utilities, and healthcare insecurities. We can't even begin to talk about quality of health if we don't have quality of life. Fourthly, we also have to move from charity to a sustainable model of care. I love the work that Donna is doing and Brandon is doing because it is moving us into a direction from charity to sustainability. Foundational work, philanthropy work is wonderful, but if that organization or funding leaves, it is not moving us towards a sustainable model of care.
Well, I tell you what, Angela, we just need to take you to the White House. We need you to get in front of the president, and we're going to lay out these 4
Absolutely.
points.
Absolutely.
So Donna and Brandon, I'm telling you, Angela has laid out for us the formula that we've got to have a partnership, that we have to engage everyone, right? That we've got to get payers involved, and we have to have a sustainable model. Anything else that you'd like to add to the recipe that she's given us today for critical change?
One of the things that I would add is making sure that we are not afraid of innovation and creativity. And I think that really kind of helps to bundle it together. You know, all of these different items, we have to think outside of the box. And I know that's, you know, very overused, but really and truly thinking about innovation and creativity, especially when we're thinking about human lives, when we're thinking about people. We're not thinking about diagnosis. We're not thinking about numbers. We're thinking about human beings, each person representing a significant life. And I love what Angela said. If we are not focused on looking at the basics and the quality of life,
yes,
what are we really doing? And so I want us to make sure that we are also looking at innovative strategies and not being afraid to pull some of the old that has worked in the past, but also really looking at ways in which we can reform our thinking about the process as well.
Oh man, Donna, you know, Angela referred to some things that you're doing in your area. When you talk about innovation, when you talk about thinking about outside the box, would you like to share any of the things that you guys have learned?
Well, definitely one of the things we've learned that will take us forward is to learn how to say yes, not look at how to say no. Everyone says no, especially in underserved areas. No is a word that's heard often. we need to figure out how to say yes. And we do that. We look at the person, we look at situations, we look at each individual case and see that person as a person. And we have to, in healthcare, bring the care back into focus and not let it be about anything but the person in the center of that care. So that's definitely a lesson that will take us forward and allow us to be of better service to our community.
Absolutely. You know, when we get down to the core, each community is made up of individual people. And when we think about when you bring someone into your organization and you take a moment to really hear what their issues are, you know, if I don't have electricity, I'm not going to want to hear about how you're going to send a nurse to help me when I'm sitting in the dark, right? And so, you know, looking at those things that we can do with the social determinants of health, but also customizing the individual's plan of care. We talk about that a lot, the individualized plan of care, but so often we get caught in the trap of how we've done it before, and we have to innovate. So Brandon, I love your remark about that. We have to not be afraid to go outside the box. We can still be compliant with the regulation, but making sure that we're providing the care that the patient and the family member need. So thank you guys so much for that. I want to address this next question, Donna, to you, because as we talk about innovation, as we talk about embracing the spiritual communities, and oftentimes I would say that most spiritual communities are not at the table for policy change. They are the last ones that are considered, and yet they are the ones that are on the front line caring for individuals in their communities. How many soup kitchens have you seen? How many folks that are clothing the homeless? Those that are there that have parish nurse ministries. So we want to do that with communities. But my question is this: what is the importance of trust when we're talking about advancing care in communities with spiritual?
You said something very significant about the relationship with community and the church and the places of worship. People are able to be served there because they trust what's happening there. They trust the individuals there. They believe that those people there are willing to help them right where they are and that they're committed to their best outcomes. Trust is the crux of relationship. It is the foundation of connection. And if a family does not feel the ability to connect with a provider and thereby trust them, the opportunity to truly serve them is lost. We can't go any further beyond the distrust, because there's always going to be an underlying feeling that they really don't matter. So we have to look at what that means. Even though the provider has the knowledge, the data, everything, the resources, everything that they can offer, the family may reject that because they don't trust it. And we have to build the relationship of trust before we can actually build the bridge to better services. Because if the trust is not there, you just can't go any further. And a person dealing with advanced illness, I've seen this again and again, has often arrived at that place through many years of self-neglect or just not being educated about disease process, all of those things, just ignorance about a lot of things. And maybe they didn't know, but if the provider treats them in a way that causes them to shrink back and not show up as a person, yes, a sick person, but show up as a person, then that's not going to serve them. And that person has to be seen as a client needing help, not just a problem to be solved. So that's the main point. People have to trust where they're going to get help. That vulnerability makes a person very, very suspicious, and you have to connect at that place.
So Donna, what are the barriers to building trust? And after Donna, I want Angela and Brandon to chime in. What do you feel are the things that put the walls up that keep trust from happening?
There's so many things, but just to name a few: overt racism in the healthcare system, barriers to healthcare access in certain communities, healthcare disparities, consumerism, fragmented patient-client relationship, lack of time in communication, just simply having a good conversation with a family about what's going on, being informed, really being present. That's a true barrier, because if you're checking off your phone and looking at the next chart and not even concerned with what my concerns are in this moment, that's going to build a wall. And we've seen it again and again. So definitely some of the major barriers right there.
Wow, wow, wow. You know, I think of accountability, you know, and integrity, that you do what you say that you're going to do. Absolutely. You know, if you say you're going to show up on Tuesday, you show up on Tuesday at the time that you said that you're going to come, or you call to let me know why you can't be there. Those are things that are so important. Angela and Brandon, what are other things that you feel are barriers to us building trust with those that we want to serve?
I would definitely like to piggyback off of what Donna has already said. Is historically speaking, it's unfortunate, but the reality is what it is that our United States in many instances have been cruel to people of color. And so how you were treated in the grocery store, how you were treated on a job, how you were treated as you walked into a clinical setting, if there is any indication that there is even an implicit bias, meaning that you have well-intentioned folks who have racial biases because we live within a system that systemically has structures that are racist. So if you've had any of that in your life, that is an issue when you walk into a place to receive care. The fact that trust is such a huge component of good care means that this relationship building is essential. I want to be real quick, but just offer an experience of mine in the community with C-TAC. In 2020, we launched a Louisville pilot project here in Kentucky, where I reside. And we partnered with faith leaders in one of the poorest zip codes in Kentucky. And we walked alongside with them. We entered into a relationship with them. Now, I'm an individual of color, but they still know me as a representative of C-TAC. And so there was time that I had to assess their needs, but I also had to journey with them. I had to be at the AARP little food drive, right? I had to be present before I could even begin to talk about advanced care planning. So my suggestion in regards to how we build trust is build relationship. Listen, Donna said it, listen to what their needs are, listen to what their concerns are. Don't just be on your phone or charting or whatever it may be present. And not only listen, but respond to what they say their immediate needs are. And if you can do that, you can build rapport.
Absolutely.
Totally agree.
Yeah, absolutely. It's a body language is so important, right?
It's true.
You know, you can, you know, right from the start, the very first meeting with that new client, that new family, right? Your body language, and you can tell whether or not someone's trying to hug the door. Even with a mask on, you can have a body language of being warm, of wanting to be there, of wanting to connect with that person. So body language is so important. Oh my goodness. Brandon, go ahead and share.
Yes, so this is a little bit different, but it's certainly interrelated with what both Donna and Angela said. The thing that I thought about immediately in terms of barriers, food deserts. And so places here in Baltimore City, for instance, we have a number of communities that are food deserts. And by definition, those are areas in which there are no grocery stores where people have access to fresh produce, fresh food. And so they have to literally go outside of their communities in order to just kind of get the basic necessities. We all need food, right? And so looking at that sustainability, if you are coming to my home and you're saying, I'm here to meet medical needs, et cetera, but let's talk about what my real needs are. I need access to food. Like, I'm in a food desert. And so how are you going to help me? How is my health going to benefit me if I can't even have fresh produce and things along those lines. And so that's what really came to mind is, are we really helping looking at those needs? And unfortunately, persons who tend to be in underserved communities don't necessarily always have the finances, the resources, or even the transportation to go outside of their community in order to have access to these fresh foods and produce, et cetera. And it creates a vicious cycle, right? Because you're then consuming things that aren't necessarily the best for your health, and you are in a situation where you need health services, right? And so you're reinforcing a very difficult issue in underserved communities. So that was really what came to my mind as well, in addition to all the other items that have been brought forth.
Thank you so much for sharing that. And as you think about food deserts, you also think about individuals who may be in an income bracket that still doesn't allow them to buy health insurance. They make too much money to get food stamps, but they don't make enough money to pay for health insurance. And so there again, you have that cycle where someone doesn't have the extra resources to be able to go see the doctor. You know, they don't have insurance that they only have to pay the copay. Now they've got to pay the whole amount. And then when you look at my income, you say that I make too much money. And so, you know, there are all of these issues that are going on that impact our communities. And I think there again, we have to be careful of not having implicit and racial bias. We did something recently with NHPCO, with our Diversity Advisory Council, and we had a session on implicit bias. And as I was a part of that webinar, and what we did was we put a picture of a couple of different homes, you know, what they look like on the outside, a couple of different individuals. And so, and we just sort of, it was, what do you think about this particular house? And one of the houses on the outside, it looked like it could have been a beach home, right? And someone thought, you know, people thought, oh, it doesn't look like it's pretty clean. It might be kind of scary if you go on the inside. But once you went on the inside the home was immaculate. It was comfortable. It was beautiful. But if you just judged it by the outside, you would have missed what was going on the inside. And so often we judge the situations that we are around, or the people that we see, the people that we serve, because we're looking on the outside and not taking the time to get to know them as a person. What are their hopes? What are their dreams? What matters most to them? What can we do to make a difference? And we must be accountable for what we say that we're going to do. Guys, this is so good. My goodness. We got to move on to the next question. It's so good. So next up, Angela, I want to ask you this question. You know, as we opened up today, I mentioned about the impact of COVID and what we have seen. I am so moved by it. I personally have been affected by it. In my family, most of us now probably have a loved one or a coworker who's been impacted with COVID. We know someone who's probably died with COVID, but we also know that it's disproportionately impacted our communities of color. And we also know that there are some inequities, of course, that have gone on as well. And so the question I want to ask you today is, what are other barriers that are there that are keeping us from addressing these social determinants of health, you know, that you've seen recently or prior to the pandemic? And is there anything that clinical providers can do to help tackle some of this? You know, I know we've dealt with the vaccine, you know, those that are vaccinated, those that are not, those communities that could not receive the vaccine just because, you know, they're in a rural area, and some of the things that were done to help those particular communities. But what can we do as clinical providers, members of health organizations, hospice and palliative care providers? What can we do to make a difference to reduce these inequities?
You know, I really truly believe that the cusp of it all is lack of understanding. And there's a scripture in the sacred text, and I don't want to get all too spiritual, but it's as you speak, you know, there's a text that talks about my people perish because of lack of knowledge.
Yes.
But many of us misinterpret that text. It is a thought that the people who have the knowledge sharing with the folks that don't have the knowledge. That's not it at all. The truth of the matter is that they did not act in love and did not act in the compassion of God to the individuals who were suffering. And so it is this piece is that we lack the understanding of really truly how to reach folks who are in a predicament. And so the crux of it all really is dealing with, do I even have implicit bias? How will you know that you have biases without appropriate training and then accountability? So as providers, we should hold ourselves to a standard that seeks out counsel on how do I understand the predicament of the underserved, you know? And so this diversity in clinical settings is a critical component, not just janitorial and food services, diversity and equity inclusion. Marissa, I know you and I are a big component of DEI training, right? Mm-hmm. Training with goals and objectives followed up with accountability measurements. And so also this whole trust and access and opportunity, support, and community messaging, we have to understand, or you as clinical providers have to understand, how do our target audience receive information? If you have not trained yourself, if you're not getting adequate training on how to get an articulation on how to have good communication skills with your target audience, i.e., the audience that is proven to statistically, right, receiving inequitable healthcare. So also, this is one piece that I really highly recommend. This sort of relationship, this sort of building begins beyond 6 months of end of life. We really, on the onset of folks who are coming into our place of treatments, whatever it may be, that you are beginning to build this relationship, gaining access or sharing access to how you go about having these sort of conversations. We did a wills and estate planning. That was how they received it, but it was really dealing with advanced care planning for one of our partner churches. And it really dealt with how you are able to walk through advanced care planning. We need to, as providers, point individuals into the direction of trusted CBOs in community that can provide this information that we can all partner with, journey with, so that folks that have their selves, persons who are receiving care, can share their choices, can share their needs, can begin to learn how to advocate for themselves. Also, I don't want to be too long because I know I'm already run out of time, but leveraging existing skill sets in patient center, this sort of interdisciplinary care, and apply them further upstream. And so, you know, again, to secure reimbursement that is sufficient to keep these sort of programs sustainable. We're also dealing with mental health fatigue. I know that we're dealing with that in our clinical settings right now. So those who are higher up, CEOs, you got to provide some, if you will, respite. I know this may be the wrong manner, but we have to provide and take care of our healthcare providers. Also, I want to say this, and then I know you're going to open it up to everyone else. We must find common ground, right? Howard Thurman, which is a great theologian, he speaks in liberation theology. He says, in times of great stress and strain in the outer environment, men tend to retreat or escape into the inner world as a place of shelter or refuge. So inner world here is feelings and aspiration. If clinical providers can carve out space to get to one's feelings and aspirations around their care and then provide that care, I'm confident we would provide better healthcare.
Mm-hmm. Thank you, Angela. So many themes there, and I want to pull on one of them that you mentioned, and that is communication. Donna, I saw in your bio, you know, I was peeping at your bio. I said, oh man, she is considered an excellent communicator when it comes to tough topics. And so when you think about being able to communicate with a patient and their family, and they may be from an underserved community, they may be Black, they may be Hispanic, they might, be of a different nationality. What have you found in terms of communication that we need to, how do we train our clinicians around communication?
That is such a big question, but it's important that we refocus and make sure that we understand that what comes from the heart really does touch the heart, and that families are in need of care entirely, mentally, physically, spiritually, emotionally. They are an entire being needing entire care. And to Angela's point about biases, I will share with you an experience prior to COVID when I was actually in the hospital setting as a liaison there on site all of the time. And I would get pulled into conversations. Many providers don't even want to say the word hospice. Many providers avoid the conversation altogether. I was with a very young couple, and it was heartbreaking because they did not even understand what was happening. But the family heard a provider say, "What's nothing more we can do? We should just refer them to hospice." It wasn't the conversation with the family. They overheard that statement made from a provider to another provider. And then when I was brought in, I was already at a disadvantage because you don't know what hospice means to people when they hear it. More often than not, they believe it means death, period. Right. They don't have an understanding of the support that it offers, the hope that it gives. They don't know that. And then I don't have an opportunity to share that because of the way the conversation is introduced. But in this particular situation, I asked them because I felt that they did not even know what was going on. I said, "What do you understand about your disease process?" Well, they said something, I said a carcinoma. And they said, yes. I said, what do you know that to mean? "Oh, I don't know." And I asked the provider to have someone else come back in to have the clinical conversation with me so that they would understand what they should have understood before I came in. Mm-hmm. When we continued the conversation, it was a whole family, because in underserved communities, oftentimes you have the whole family as support.
Absolutely.
So everybody was there, but nobody knew that there was cancer. Mm-hmm. Nobody. Mm-hmm. And when they said that word, the eruption of emotion, it brings tears to my eyes now, because all you could see is that they just felt like it was over, period. Nothing more to discuss. But the conversation continued in a different way because of information that gave them more insight. They were devastated in that moment, but I was able to say to them, "I understand this is difficult. I am so sorry that I'm coming to you in this moment, but I'm happy to be here because we can help you. We can support you." And that's what people need to know. Can you help me? Can you support me? And how? How will you do that? Mm-hmm. But I say all of the time, if you can't see me, you cannot serve me.
Mm. And so often people will say, "I don't see color." I have to pause right here to say that.
Right.
And that is a term sometimes that can be very offensive, because the person hearing that, I understand that the intent of that statement is that I'm not going to treat you any differently because of your color. That's the intent that you want the person to feel. But what the person receives is that you don't see me as I am. I'm an African-American, 62-year-old woman who has a whole history of stuff going on with me. I'm a wife, I'm a mother, I'm a nurse. I have all these things going on with me. And when you say that you don't see my color, you're missing a part of who I am. And so communication is so important in terms of defining what someone knows and what they don't know. And taking the time to do that, to ask the right questions. So Brandon, I know you're on the edge of your seat. You're wanting to chime in. And so us ladies, we're going to pause and let you chime in, Brandon. Go for it.
Oh, goodness. I tell you, there's so much richness in this conversation. There's so much here. I'm just so grateful to be a part of this. And one of the things that I really just wanted to pull in is really that piece about hope, as well as advocacy, because what everyone is saying here leads right in that direction. And something that Donna said earlier was so profound to me, that trust is really the crux of things, in terms of leading into how we serve and how we care for people. And absolutely positively, it's that trust that is the crux, and trust inspires hope. And when we are able to go in and build relationships, and sometimes it's within the first 5 minutes and it feels like we've known them all our lives, right? Sometimes it takes longer than that to build that trust, but by building that trust, it opens the door for hope to be inspired in them, but it also provides an avenue for us to advocate on their behalf, particularly those people who are in the shadows, those people who don't have a voice, those people who feel like they're not empowered or no one cares, no one's listening. We get to then take that and we get to open the door for their voice to be heard and advocate on behalf of them. And one of the things that I really thought about was a situation that I had several years ago where I was called in to provide spiritual support for a patient who did not, really feel like he was a part of any spiritual or religious entity, but he lived with his mother, and his mother said, "I need the chaplain to come." And I went to meet with this patient, and he was sitting in his wheelchair, and he was in his 40s, a very young man. And he had his head down. And so for the first 5 minutes of our interaction together, he never looked at me. His head was down. And I was seated on the couch, and I was just kind of trying to figure out, how can I find a way to build trust with this particular individual? And I noticed over his shoulder, there was a picture of him in his younger days. And it had New Orleans, the city of New Orleans was on the frame. And I asked him, I said, "Well, hey, tell me about New Orleans." And that was the first time that he lifted his eyes and gave me direct eye contact. And the man shared all of these stories, and it inspired hope. And Angela, you were talking about, sacred texts, and things like that. It reminded me of a future with hope. It doesn't matter how much time I have left, but can you draw that trust out of me? And it was such an interesting encounter. And at the end of that first visit with him, I stepped into the kitchen to let his mother know that we had concluded the visit and I was going to leave. His mother lunged at me and she grabbed me by my shoulders and she started shaking me. And she said, "I don't know what you said. I don't know what you did, but this is the first time that I've heard my son laugh in a year." And she just cried. And it was just as simple as really getting to know this, asking something specific about his life, things that were important to him. And, just to, wrap the story up, I continued to visit him very regularly, and he would just share these stories. And as he began to decline due to disease progression, I would go and visit with him. I would, give him ice chips. And then it reached a point where he could no longer speak. I would share his stories back to him until he passed. And it was that sort of thing. There was hope there. He had hope knowing that someone was there, someone cared, and he was able to build enough trust to be able to share some of the most intimate details of his life. And I was able to advocate on behalf of that patient. When he started declining, there was advocacy. Let's meet with the team. Let's get him to our inpatient unit where he can be comfortable and his symptoms can be managed. And that's where he ended up passing. But it was a very beautiful experience to be able to build that trust, inspire that hope, and then advocate for him.
Thank you so much, Brandon, for that. So often we think about hope as hope for a cure. Right. And we don't look at hope in terms of the increments of hope that we can give to someone. Hope that I won't be in pain. Hope that I can see a loved one that before I die, that there's someone that I want to see. Hope that I can have the quality of life with the time that I have remaining. And so when you talked about reframing hope for this patient and connecting with something that mattered to him, so often we come in with our own agenda. And I love the fact that you demonstrated for us that your visit was not about your agenda. Your visit was about what was going to impact him in a positive way. And you prayed, I'm sure, and you saw that picture behind him, and it opened up something because you went with that. You know, oftentimes everything's not going to be scripted, but it goes back to what Donna says in terms of authenticity of your heart. I might be a different race than you. I might live in a different zip code than you live in. But what matters is our connection of terms of caring. And that connection will it'll be the bridge that will get us across our differences, right? So man, that was just really good. I want to move to advocacy before we finish today and we open up for some questions, because I know that we have some folks that want to give us some questions. And thank you, Jessica, for keeping us on the time check. And so I want to ask, I want to talk a little bit about advocacy and what are some key strategies to leading advocacy within your organization, in addition to the community at large. You know, oftentimes you want to start with the community. And my adage is that we have to work from the inside out, that I have to begin inside my organization, being aware and being sensitive and changing things internally for our diverse culture inside our organization before we go outside. And so I want each of you to sort of talk about how do we advocate internally, and then how do we transition that to the community? And I'm going to start with you, Brandon.
Thank you. I think the number one thing is, first of all, education. People need to know, what is it actually that you're advocating for? Do you have an understanding of what you're advocating for? What does advocacy look like? And so internally, it can be simple as being the example. You know, if there are things that you want to see in your organization, institution, establishment, sometimes you have to be that example. And by being that example, you advocate on behalf of other opportunities like that. But people need to understand, I mean, if it's from, let's just say a chaplaincy or spiritual care perspective, this is what a chaplain does. This is what a chaplain looks like. This is how a chaplain provides care. It's, you know, it sounds simple, but it can be a very weighty task, particularly if others are not necessarily on the same page or don't have the same set of values. But you have to present that in such a manner in which you continue to advocate. Advocacy is not a one-time thing. It's not a, you know, you just state your case and then you move forward. It takes a lot. You have to be present and really strengthen and build that trust. You have to build the trust with the leadership, with the administration, and let them know that you are reliable, that you are there, and that you are a source of advocacy on behalf of others. If it's for, you know, positions, if it's for a certain type of care or whatever the case may be, advocacy is so key. But it starts by you being an example and using your voice. And sometimes we feel like I'm the voice of one crying out, but I guarantee if there are others who are a part of that, who really understand, who share those same values, they will join alongside of you, and then you will become a force of advocacy. But sometimes it starts with that voice of one person. And don't allow your voice to be minimized or stifled, because, you know, sometimes there is that sense of, well, I don't see color. But if you don't see color, you don't see me. And so I have to then advocate for ways in which you can see me. And maybe it starts with me using my voice.
How about you, Donna?
I 100% agree. As I stated earlier, it's always been my position, if you can't see me, then you can't serve me. And advocacy really is simply saying, I care about what you care about. Let's care about it together. And let's move the conversation. All right, Brandon, I saw that. No, but honestly, it's just really being able to be relatable and saying, listen, I'm a person, you're a person. We care about each other in ways that other people may not understand. You may not understand how I care about you because I might not be able to communicate it. Teach me how to communicate to you about how I care about you. Don't just assume that I don't care. Help me learn how to care about you. And that's what advocacy is to me. And that does start internally. You know, we have to change the way we think. We have to change the way that we look at things. We have to be open to change and give it an opportunity to do what it does. But if you don't give change a chance, then it won't ever happen. So we have to give the opportunity for the changes to take effect.
Angela, you're engaged in, thank you so much, Donna. You're engaged in so much in terms of looking at advocacy, you know, so much work that C-TAC and NHPCO are doing related to advocating in the spaces of diversity and equity and inclusion and spiritual care, and what you've seen across the country. What would be the advice that you would give to leaders and organizations who are listening to us today about where to begin?
Marissa, that is such a huge question.
You guys have the answers.
It's like 60 seconds because we have to move to Q&A. Listen, C-TAC is all about policy and advocacy, but we cannot gather the stories. We cannot gather, if you will, evidence to really provide support to the need for change legislation if we do not enter into relationship. So the Interfaith Work Group, the Advisory Council, working with faith leaders throughout the United States, it is really providing them with information so that they can gain their voice. With the historical ramification, this has also created a social stance that I must be quiet and listen to the experts. Many times, providers do not even provide a space, just like Brandon has just mentioned in his setting of just being present, right? Many times we can't afford that space. That's what we say. We cannot afford this space. We don't have the capacity to listen. Or to enter into DEI training, which helps in our messaging and our communication skills. So listening is critical, but it also means that you're in a position where you're going to journey with. That means that you're going to, we can begin to partner with, AARP. We can partner with, Conversational Project. There's so many other providers and partners in our community that we partner with to share these resources on how you can begin as patient to advocate for yourself, as a caregiver, how to advocate for yourself. But I have to say this, when an individual says, this is what I'm experiencing, providers, you have to listen. You have to listen to them articulate what is ailing them, as well as their wishes. Many times people say, I don't want hospice care because they lack the understanding of actually, Donna has just mentioned, what is hospice care? What are the advantages? It's not a hopelessness, it's a state of hope. We want to, and if you can find this common ground, oh, these are your goals. Oh, I heard when you say this is this, explaining medically what is happening, and then to be able to give them the information that they can in turn say, hey, this is how I'd like to advocate for myself. Advocacy simply means really participating in a cause. So yes. The cause is that you're valuing this individual's life enough to be at the place where we all can be at the table. I know that's all the time I have. That's all I can give.
Oh my gosh, we may have to do a part 2. I want to, before we open up for questions, I want to throw out something for our providers to think about. Oftentimes health systems put together volunteer advisory boards, and they get patients or patient care advisory boards. They get patients from the community to sit on their boards in terms of care and get input from them about what they could do better. I think in the same way, our hospice and palliative care organizations can take a page out of their book, and we could create innovative advisory boards, if you will, from the communities that you serve, where from the relationships that you are building, you get individuals that will be a partner with you in the care that you're providing to that community, and get them to be your focus group to tell you what will work and what will not work. It's so important for you to get their input. And so often we're wanting to provide the care and it's going this way, and we're not having an exchange of ideas, of things that can make the situation better. And so as you think about this year, you have 11 and a half months to make a difference in the communities that you serve. And so it won't hurt you to have one Zoom meeting where you invite some partners from the community, or 2 or 3 Zoom meetings once every quarter to get their feedback on what you are doing. And to also, survey your own teams. How are they doing? As we talk about hope, one of the things our teams need is hope that it's going to get better in terms of the COVID mental fatigue. And so we want to be able to provide that so that our teams can remain resilient. And so that is going to be important for us as well. We have certainly enjoyed our time with you this afternoon, and now we're going to take your questions. So I'm going to pause. I know Nicole is on with us. She's the chair of the Diversity Advisory Council at NHPCO. She's helping us with our questions today. And so what is our first question?
So I can tell you, thank you, Marissette. And I'm just going to speak on behalf of everyone that you all have been phenomenal. So I'm just going to throw that on out there, because as one who's just been sitting here in the background listening, amazing. And thank you all so much, so much. Our first question comes from Leon Maxwell, who has actually submitted 2, but they're both really great questions. And he asks, how do we get the healthcare providers to see the person who was created in God's image to receive the best care moving forward? Wow. So I'm going to ask maybe 1 or 2 of you to respond to this one, because the questions are coming on in.
Angela, you look like you want to take it.
and Brandon looked like he wanted to take it too. So.
Listen, they both were like, so by all means.
Go for it, guys.
Go ahead, Reverend Brewer.
Oh, goodness gracious. Oh, my. I think this is one of those ways in which we have to live the example, because we also have to recognize that while, we all may be a part of a particular faith group or denomination, et cetera, not everyone values or believes in the same manner. And so we have to live the example. We have to show that we care for this person, regardless of anything about them. If we can just connect as human beings, and this has, been said, earlier as well, if we just connect on the level of humanity, this is another person that I can look at eyeball to eyeball, or, provide care for. That's how we have to go about it. We have to be very delicate. There are regulations around, religion and things like that. And so we want to make sure that we're doing everything that we can from the perspective of being the example, and really showing that and exuding that, so that others will see something in us that will cause them to want to function in a manner that is similar.
Angela, anything to add?
We really, I think, oh, this is such a hard question, but it's really, really good. This is a human issue. Yes. To live in a society where you have individuals who are experiencing houselessness, proper nutrition, and good health care in a nation with lush capacity is a human condition. Now, if we can see the individuals that we are providing care for as human, as we do our mother, our sister, our brother, our father, that is the relevance of God, right? But it doesn't mean you have to believe in the God that I believe in order to see an individual as human. And so my piece on this is that when we're, again, in training, we are teaching our providers to operate in the capacity that we provide good health care to all.
Wow. I think it also begins to in training before they get out, you know, that we have to change our curriculums, you know, that we've got to do something in our nursing curriculums, our social work curriculums, our physician med school training, our social work training. You know, we've got to change the curriculum so that we see the whole person.
Yeah, the bedside manner. Bedside manner, Maricette, you know? Is that really taught in, even we can say in seminary, in residency, you know, in our nursing schooling and all of that.
Absolutely. I remember as a new nurse, I worked on the cancer unit, was the first unit I worked on, and I absolutely fell in love with it. And my mentor, I loved her because she modeled for me that it wasn't just about when I went into the room, me taking care of the IV, the chemo, the blood. It was about me making sure the room was clean. We emptied trash cans. We made sure the pillows were just right on the person's head, that their covers were right, that they were dry, and that we took care of the environment so they felt cared for. And so often we want to jump to the medical pieces and not start with the caring pieces first and know that those things follow. So thank you so much for that. Nicole, I think we have time maybe only for one more question.
You know what, Maricette, I believe in all of your victory that we can get through too. So I am going to, and I say that because one is essentially a follow-up to a point that you just made. And I'm going to ask Angela to give me a brief response here on, as we're talking about the opportunities for really addressing these needs from an academic perspective. How can we, we've been talking a lot about advocacy. How can we start to advocate for that to be a part of the expectations during training, right? Before anyone's even going out and seeing patients regularly? How can we advocate for that?
It's interesting that you asked this question. And I think the tides have changed in our academic scholarship, the scholarly, deans as well as presidents, I think are understanding the need for this education. And already I've seen in many seminaries there's a trend where it's changing, where they are changing their curriculum and dealing with more practical teaching in as far as the degree requirements. I think that here again, you need to enter into partnership with academic scholarship and scholarly leaders and CFO, directors, presidents, and to begin to have those conversations. So, just like we're inviting to the table payers and stakeholders, we perhaps need to think about adding into those infrastructures who start at that level of academic scholarship.
Awesome. What's our next question, Nicole?
I'm going to ask one more, and it will be a challenging one, especially since I'm going to ask everyone to answer it individually in 20 seconds or less.
Oh, the clock is ticking.
Yes. And Maricette, you know how I am with our meetings. We're sticking to the time.
That's right. She keeps us on task. Go.
So, what gives each of you hope in the work that you do so that it translates to give hope to others?
20 seconds, huh? Okay. For me, I am able to see hope in everything. Just very quickly, my mother is currently very sick. And I know that I was brought to this work so that I could prepare myself and my family for this experience, but more than that, other families, so that I would care for them like I care for my own. So I'm given hope by what I know exists on the other side of bad news.
Mm-hmm. Yes, Brandon.
Oh, goodness. I think hope itself reinforces hope within me. Being able to be a part of a narrative that is not just my own, really is impactful. And that gives me so much hope because there's the opportunity to be a part of something greater. It doesn't have to be something that benefits me or serves me in a particular way, but being able to meet the needs of others, it reinforces that sense of belonging and that sense of hope that inspires others.
So, Angela.
Hope for me is having only positive expectations in this life or the next. And so my hope is that every person I journey with is their life will be better. This is not meant to be arrogant or to the point where, no, it's just that I want to get to know you so well that your life is improved because of whatever I have access to, you have access to. So my hope is that I will improve the lives of those I encounter.
My hope is in the power of partnership and collaboration. I don't care what venue it is. I always believe that if we come together, we can make it better. I don't care if it's me talking with my husband about how we're going to get our budget straight this year, or if it's me around the table with a board, or if it's with me with all of our national partners. I believe that we can make a difference. And that gives me hope because I see the outcome of that. Thank you guys so much for joining us today. It has been an amazing dialogue, and we hope that you have enjoyed it as much as we have. We want you to know that the recording of today's webinar will be posted on all of our websites. So NHPCO, C-TAC, as well as the National Partnership for Healthcare and Hospice Innovation. So we want you to know that you'll be able to access this, share it with your teams. We don't want this to be a one and done kind of conversation. And let us know when you get the evaluation, what other topics you'd like for us to explore. What are some other things that you want to hear about? And we're going to be going back to the drawing board because as a partnership, national partnership, we are committed to working with health and equity and spiritual concerns. So this won't be the last time you hear from us. Thank you again and have a wonderful afternoon. Bye-bye. Thanks, guys.